Sorry.
I'm
Hello,
good.
there,
I'm good.
both of you.
How are you, sir?
Good, good. Hi, Bhavna. Bhavna, I think is. Uh, good morning, Rhea.
Morning.
Rhea's mutant morning. So today, Rhea would be co-reporting with. She's a co-reporter with Kandar. It's the first time she'll be doing that. She's our intern from University of Maryland.
Welcome, Rhea. Time to rock.
Yamini. Uh, good morning, Yamini.
Good morning. How are you?
Good. Are you in Boston or Westford?
Westford.
Good. It's good you're at parents' place.
I know. They're still not awake. I'm surprised.
Right. Um, Greg, I think you're meeting Yamini virtually first time.
Yes, hi,
Yeah.
Emily.
Yamini
Hi.
and Greg are working together for almost a year. She's a JSPH intern with Greg. We have quite a few students in the US who are working with Greg as interns and fellows. Actually, we started virtual fellowship, Greg and I, almost a year ago, right, Greg?
Yeah, a little more than a year ago.
Yeah. Before COVID-19, we started that virtual internship and virtual fellowship. Slowly, we are merging with Jodhpur and Jaipur, Poornima and Maulana Azad and JSPH.
And I'm getting more comfortable with it too.
Good, good. Hi, Vibha.
Hello, sir. Good morning.
Morning. Vibha was our first JSPH student in 2008 when people in India, especially in Jodhpur, did not accept public health.
Thank
And
you
today,
for that, sir.
sure, it's an honor for me. You started the engine for us. If you did not come up, we would not be here today.
Yes.
You
Not
were,
like that, sir. It's all your motivation, sir.
it's the first student. How are you, Rahul?
Sally needs a Zoom link.
Oh, okay.
She just texted us.
Bhupesh, could you please?
I'll share it. And otherwise we're going.
Yes.
So we are going live, right?
Yep.
Okay.
Yeah. So we are live now, and I'm sharing the link with Sally. I've sent the link to Sally. So all of us are live. We are on live on Facebook and YouTube, and we are on. We're going live on Facebook pages of Poornima University, JSPH, Indic Chain, and Medipulse Hospital, Jodhpur. So I welcome all the esteemed panelists. You have to mute yourself for a minute so that I can introduce everyone, and I welcome everyone. So hello everyone, I'm Rahul Singhi. I'm the director at Poornima Group and co-founder of Poornima University, Jaipur. And I joined in, my father, he's an architect by profession, and I joined him after graduating from an architecture school from Jaipur and in 2011. And since 2012, I've been, been part and parcel of Poornima University, from designing to construction to now running the institution along with a team of around 800 people in Jaipur. Now we have roughly 8,000 students. We were originally an engineering college which started in the year 2000 with a strength of around 140. And now we are a family of around 8,000 students, as I said. We also have our sister concern in the name of Jodhpur Institute of Engineering and Technology in Jodhpur, which is also a big institution in terms of the strength of students. There are about 4,000 students there and about 400 faculty staff in Jodhpur. And when we started hospital, my father, he got in touch with Anil sir, and rather Mayank got in touch with Anil sir, and then they introduced me to Anil sir. And then I came to know about the public health courses that JSPH runs in Jodhpur. And I was very keen to start something in public health domain at Jaipur, because I have that, I always try to bring in new courses, unconventional courses in the university on regular basis. So that's how I got in conversation with Bhavna ma'am, Kandar. We were the first people to discuss about our relationship in terms of, starting the courses. I still remember a very short meeting on a Sunday morning. And then finally I met Anil sir, and then we started off with some courses in masters and bachelors. And now the bond is now getting stronger and stronger. Every fortnight we are conducting webisodes on health, on public health. A lot of students of Poornima, they see the webinar, they see the webisode. A lot of our friends, family from the education as well as from the health background. So I would first like to introduce Anil sir I'm just going through a small presentation so that everyone is introduced well. So this is Poornima University, and I would like to tell something about Anil sir, who is having 30 years of experience in establishing and running HIV/AIDS programs in Africa, Asia Pacific, North America, and West Indies. He sits on various boards, including stem cell, IVF programs, technology companies, and academic centers, apart from also being the CEO and president and founder of Jodhpur School of Public Health. Dr. Anil has also worked for FXB as the Global AIDS Director and as Executive Director of FXB USA and India, and establishing 44 plus AIDS program. He has been recipient of grants from Bill and Melinda Gates Foundation, Tata Trust, World AIDS Foundation, among the other agencies. So it's a very nostalgic story with Anil sir, coming from Jodhpur, my maternal place being Jodhpur, and, coming together in Jaipur to start something in public health space. So I'm looking forward for a valuable contribution from everyone in this webisode, which will always be there on our social media handles. So over to you, Anil sir, if you can briefly introduce JSPH and then all the panelists, and then we'll start the formal webinar.
Thank you, Rahul. Let me start with Rahul. Rahul is an architect by training, as you said, and his father is an architect. They are the co-founders of the Poornima University, a very prestigious engineering institute where we are adding public health to it now. And Rahul and I met 2 years ago. I was flying to Boston from Delhi, and we had changed our plans that, okay, let's go and meet Rahul in Jaipur. So I flew back from Delhi, changed my trip to Geneva at that time, was going to stop in Geneva on way to Boston, and called Bhupesh Advani, who's our public relations director, to Jaipur. We went to meet Rahul. We had a very good discussion about, and we were just discussing this. It took almost a year. And then last year, July 31st, almost a year today, we launched the JSPH at Poornima University. So now we have School of Public Health at Poornima University. We also met the Vice Chancellor, Dr. Padi, almost a year ago. I met him, I believe, on 28th of July, and it's almost a year. And that's how we began with MOU. We launched JSPH, we started classes. And the day of the launch, we conferred to our topmost public health professionals in India and outside global public health diplomacy diplomas. And that was the beginning of the School of Public Health and JSPH branch in Jaipur. Rahul is very innovative. He looks into new programs. He's a very supportive person for the public health. He likes to reach to urban slums, rural areas, and empower the children and the forgotten people. It's been a great fun working with Rahul for a year, and we are in touch on a regular basis. And also, at the same time, Rahul mentioned his maternal places. Jodhpur is, so is mine, and so is Jagdish's. But also, I think Rahul's parents come from Siroi Sumerpur area, 100 probably kilometers from Jodhpur, and there where we started the Gates funded project. And it's a very historical day for us today because Rahul is from, originally his parents from Siroi Sumerpur. And that project went from Siroi Sumerpur to Jodhpur and other places of India, Mumbai, Chennai, and today everybody's here. And the best part is that Sally Stansfield is here today from Seattle. She was my program director, who was an associate director at Bill and Melinda Gates Foundation at that time. And I worked with her hand to glove on this particular project. So I think it's a very historical day for all of us. Sally being here and the presence of Jodhpur, Sumerpur, Mumbai, Chennai, Calcutta. I think this is just a fantastic day. So this is a little introduction about Rahul and how JSPH started. And JSPH was more a passion than kind of a university or something we thought about. Studying in Boston undergrad at Northeastern University and Harvard, I always traveled to Africa and India to learn what public health is, what rural health is. And I'm like, why don't we have schools of public health in India? And 1.3 billion population. I told my former boss, the Countess Albina, who endowed the FXB Center at Harvard and other places. And she said, why don't we start one? At that time, there was only one school of public health, which is, again, All India School of Hygiene and Tropical Medicine in Kolkata, but that too only for doctors, not for health professionals or engineers or other professionals. So she said, why don't we start one? We started working on it. Then I think we separated. And out of passion, one night I was visiting the antiretroviral clinic in Jodhpur, visiting Dr. Arvind Mathur, who was the leading HIV clinician there. And we thought we'll just start with tuition, and a very little tuition we used to charge. And we started with 3 or 4 students. One of the students is here today. I'm very proud of her, Vibha. And that was the journey. We began with 2 or 3 students. And as of today, we have conferred around 480 plus MPH degrees. And we'll be soon conferring 2 PhDs. One will be again Vibha, and also the Bachelors of Public Health. This is just art of passion, and that's why we are here. And I also like to announce very clearly, because I know a lot of people are from the government, from United Nations. We are some of these civil servants sitting here. This particular webinar, or these webinars, are totally academic for the community, for the global citizens. There's no monetary exchange. There are no funding from tobacco companies, alcohol companies, pharmaceutical companies, and it's totally the time which everybody here on the panel and moderators, reporters who are donating their time. It's their commitment, it is the passion, and that's why we all are here. So I want to make it a very clear point that there's no monetary exchange, that it's not a revenue-based webinar, and none of these members sitting here in front of you all are charging anything or paying us anything. So that's a little introduction and about Rahul and Poornima and JSPH. And I'd like to move forward with Dr. Padi. I don't see him today. I think he will be
he'll join us soon, sir.
That's perfectly fine. He's going to be doing the closing of the webinar. So I would start with our today's moderators, Jagdish Harsh. Jagdish is a physician by training, and he runs a company called Mobiloid, and the Mobiloid group of companies based out of Delhi as a headquarter, with offices in Mumbai, Boston, Singapore, London. I sit on his boards. We work together. 20 years ago, we started working together. And again, that was the first project he came to work with us on, Bill and Melinda Gates Foundation funded on migrant workers' health. And that was the HIV pandemic. And today we are in COVID-19 and coronavirus. And again, we are working on similar projects together. He has also been the editor of HIV Atlas. And there are lots of projects we do together. And very soon, Mobiloid group of companies will begin technology programs at Mobiloid, at Mobiloid Foundation and Poornima University and Maulana Azad University. And you'll be hearing from Jagdish about Indic chain as we go forward. Dr. Gregory Fenton. Officially, he is at the Veterans Administration at United States, epidemiologist, but he's here totally in the capacity of a visiting professor at Jodhpur School of Public Health, and he's also an executive director for the Epi Society at Jodhpur School of Public Health. Greg and I worked together for a while in the same building at Health and Human Services. I used to see him in the corridor all the time, actually, and going into staff meetings or restrooms or whatever. I never thought I'll work with this person, actually. And now he's with the Veterans Administration, but we did spend a couple years, seeing each other, but not talking to each other. We don't know who each of us were. Greg travels to Jodhpur 2 or 3 times a year. He teaches biostatics. He teaches epidemiology. He's one of our favorite teachers in research for all our MPH students. And he has been rated the top biostatistics teacher and epidemiology researcher at the Jodhpur School of Public Health. And as we go forward, we'll hear more from him. And he likes to talk, so he's moderating. And welcome, Greg. Akshay Baheti. Akshay is a radio oncologist. His specialty is oncoimaging of abdomen and pediatric imaging. And he is a blogger. He runs his blogs on radiology and medical journalism. And I don't get into his medical journalism a lot because there's a lot of facts and figures of the politics around the world, but he writes very well. He also has a travel blog. He was trained in Mumbai as a medical doctor, did his MBBS and MD, and then he did his fellowship at Dana-Farber Cancer Institute at the Harvard Medical School, major teaching hospital of Harvard. And then he moved to Seattle at University of Washington for another fellowship. And he is still instructor at University of Washington. Interestingly, today, we 3-4 of us are who have partnerships with University of Washington. My desk funds University of Washington on PEPFAR project. Sally has a visiting appointment. Akshay is here. I think every webinar we're seeing someone from Harvard and University of Washington. And JSPH is a major partner with University of Washington. We run all the online courses, and Jodhpur School of Public Health is the hub for them. And probably we have so far certified, I would say, close to 600 doctors and students through University of Washington. Thank you, Akshay. Bhavna Sati and I met 20 years ago. She's a clinical nutritionist. Again, she was hired on the Migrant Healthcare Workers Project, and she now heads our Jodhpur School of Public Health on the academic wing, Jodhpur and Jaipur. And she is very passionate, one of the top public health professional women I have known. And she's our backbone for the all the academic programs we run. Welcome, Bhavna. Hormez Godrej. Hormez, known him, I think probably when he was in primary school, I guess. And he just graduated from Stanford with statistics and master's in statistics. His undergraduate is in computational biology. And he is very passionate about artificial intelligence, healthcare. And we will hear as we go along and when his turn comes about what he does and what his interests are. Thank you, Hormez. Keshav Sakla. Keshav is based out of London. He is the lead for Solutions for Health, a very innovative company in England, established by his parents, Lena and Kishore. And he has so many things to offer in artificial intelligence. I cannot just keep on talking about everybody in detail because I think we'll just finish the whole webinar in that. But Keshav is very passionate about AI, healthcare. He wants to reach to the world with all his technology. One of his best technology I have gone through a scene and also seen the video of Bella quit smoking. And this is AI powered robot, and the robot the robot coaches as human beings how to quit smoking. And it has been very successful, and that can be used around the world. You could download on app, Google Play. And as we go along, Keshav will tell us more about it. He's a very good orator. He advises the CEOs on AI strategies and business and finance of these kind of programs. So thank you, Keshav. We'd like to hear more from you when your turn comes. My friend Mayank Singhi and I met probably two and a half years ago. And as Rahul mentioned, today we are here partly because of Mayank. We met in Jodhpur, and he introduced me to his dad. And he was very passionate about technology, public health, and he has pushed into it. And now I work with Rahul because of Mayank, and he's very supportive. He is the director for the strategy at Medipulse Hospital, one of the top notch hospitals in Jodhpur. We're trying to make it very cost effective for difficult to reach population. We do a lot of projects with Mayank, and as the time rolls, we'll be doing more and more work with Mayank. Thank you, Mayank. Naresh Ramarajan. We met very briefly once at MIT campus. I have known his partner Gitika Srivastava, the co-founder of Navya. And Naresh, by training, he's a medical doctor. He did his undergraduate at Harvard College with a fellowship from Rockefeller Memorial Fellowship. He went to Stanford to do his medical studies. He did his MD at Stanford, and he is a certified diplomat of American Board of Emergency Medicine and Internal Medicine. And he is the chief medical officer at Navya. And he's very passionate about artificial intelligence and also how to reach to the most forgotten people of this world. So we'll be hearing from Naresh when we talk to him. Sally Stansfield, I think I've introduced all of you, but Sally Stansfield comes with 30 plus years of experience in public health. She's a clinician trained at University of Washington as a medical doctor. She has worked in Cambodia. She's been a professor in Ethiopia at the medical school. She has worked for USAID as a medical researcher, as a medical doctor. She was, as I said, my program director and she associate director at the Bill and Melinda Gates Foundation. And she has done wonderful work there. Then she moved to WHO as the executive director for Global Metrics Network. That was back, I think, 15 years ago when people didn't even want to get into metrics. She did all that great work. Then she moved to Deloitte as a consultant. And now she runs the Inform Health as a director. She lives between US, France, and also in Canada, where his son recently graduated from London School of Hygiene and Tropical Medicine. Sally is a wonderful person. We've known each other for 20 plus years. And when I spoke to her a week ago, I thought I was just talking to her every day, actually. So we're so honored. And Sally, I think people are really looking forward to hearing from you. And a lot of people on the panel and in the audience know you. Welcome, Sally. Sujay Kakarmat, I think it's a very interesting day. He's also from Harvard Medical School. Most of us have worked there or studied there. He's a clinical fellow of AI at Mass General Brigham. At Harvard, we like to change the names very frequently. So it used to be Massachusetts General Hospital and Brigham and Women's Hospital, two major hospitals of Harvard. One of the two major hospitals. They merged as partners. Now they're called Mass General Brigham, which I just found out from Sujay, I think a week ago. His passion is reaching to the rural population of India and Tanzania, and he does some projects on that. He's the lead on this project at Mass General Hospital and Brigham and Women's Hospital. I'm sorry, I'm so used to those two names, so it's hard for me to say Mass General Brigham. And he would be talking to us about what he does at the Massachusetts General Hospital and what kind of work he's done on cardiovascular diseases and cancer in the past. We're so proud to have you, Sujay. Suresh Manuswamy, very talented person. He has led the PHFI Health Informatics. He has been a recipient of one of the most prestigious grant in India from the Department of Science and Technology, which Dr. Harshvardhan is the minister, who is also on our faculty, and we work very closely with Dr. Harshvardhan, the health minister. He's an otolaryngologist. Sorry, he is an ENT surgeon. He did the most wonderful work on polio eradication in India. Suresh is based out of Hyderabad. He teaches at schools of public health. He has his MBBS from India. He did his MPH from Oxford. His PhD is from University of Tokyo. And he would be talking about the health informatics and how he's driving that at one of the largest public health institutes in India. Welcome, Suresh. Okay, Vibha Joshi, I like to start with. She was our first student at Jodhpur School of Public Health. I met her the first day when we launched on 2nd October 2008. And she joined with Nitin and Vikas and one other person. Nitin now is her husband, who's also a dental surgeon. And I'm very, very thankful an honor to know Vibha, Nitin, and Vikas, who came to us as the first students when people would not even talk about public health, especially in a place like Jodhpur. And they were our first students. And today, I think we are reaching almost 500 students who graduated from our institutes. And without them, we would not be here today. So thank you very much, all our students. And I think the thank goes to the community and the students. Vibha is currently at All India Institute of Medical Sciences in Jodhpur as a scientist. She's also a visiting faculty at JSPH, and she led the Lachu College Public Health Department for 8 years as the head of the department. And as a single-handed, she started that, and she brought it up to the top level for 8 years. And we are very proud of Vibha, and thanks for being here. Adarsh, very, I think, busy person. It took us 3 weeks to get connected, and hence he's a special guest today. He has developed the digital stethoscope. We would be hearing from him. He'll be showing us a 2 or 3 minute demo. He has designed the digital stethoscope. He's based out of IIT in Mumbai, and he works with the Indian Telemedicine Association. He works very closely in Jaipur with Mahatma Gandhi Hospital, and we're so proud to have Adarsh here. He's doing wonderful work in India with lots of doctors, with lots of people around the world. And we would hear about his company, which came out of IIT. And we're glad to have you. Kandar Mathur, he's also a graduate of JSPH. He did his MPH with us last year. He has climbed up the ladder. Now he's visiting, well, he's an assistant professor, not a visiting faculty, he was. And currently he's our backbone for all the webinars and a lot of things we do at JSPH. He's a dental surgeon by training. He also has hospital management experience, and he's one of my, if I could say, chief of staff actually right now for last 2 months. He in the COVID-19, he's driving me, keeping me in order, and our team. And he's going to be our report here today. Thank you, Kandar. Rhea is an intern. This is her 4th webinar, probably. I think it's the first month, yes. 4th webinar, first month. And she has done wonderful work so far, writing reports. And she would be a co-reporter with Kandar today. Thank you, Rhea. Yamini Kumar from Boston, my neighborhood in Westford. And she is an undergrad at Massachusetts College of Pharmacy and Health Sciences. She would like to go to medical school, and it's her 2nd day today, and she's interning with us, but she has been interning with Gregory Fenn for last more than a year. And we look forward working with Yamini, and maybe she'll be on a panel next time. Thank you, Yamini. Honorable Vice Chancellor, Dr. Suresh Chandra Padi. He's the president and vice chancellor at Poornima University. He joined, as I said, last year, and I met him first time on 28th of July. And he has the largest network of any vice chancellor I've known. Very good administrative skills, excellent support of academics, and he loves to empower people and work with children. And we're very proud that Dr. Padi has been very, very supportive to School of Public Health. So that's all our introduction. And I would take this forward and give it to the moderator, and I would like to hand over it to Jagdish. And Jagdish, before you start asking questions, if you could give us a brief introduction about what Indic chain is and what are you going to do with JSPH and Poornima, briefly.
Jagdish bhai, you have to unmute. Yes,
Okay,
you
I'll
have to
start.
repeat.
Yeah. So yeah, thank you, Anil, and welcome everybody again. I think we have a great panel today. I'm co-moderating with Greg, my friend, and we have a lot of experience, a lot of exuberance in the panel. And this is the favorite topic of all, digital health. It's concerning everybody in this Corona era. And so, as Anil said, Indic Chain is a offshoot of Mobiloid group of companies. Mobiloid is into new digital technologies. We are a services company, software services company. So we have been into blockchain, AI, IoT, and mobile technology, and have been working with mostly mobile apps, with these backbone technologies. So we were realizing that there is a gap in the digital skills. So IndicChain we like to call as the digital skills wallet. So it's a digital wallet of digital skills, and we are trying to train, and as we write on IndicChain, that we are trying to create on a mission to create the world's largest talent pool of digital technologies. And when we say that, we really need people for working in digital health, digital agriculture, digital farming, and digitizing the society and the life skills that come with it. So IndicChain, we are partnering definitely with Poornima University. We are setting up our digital COE, that is Digital Center of Excellence, and that's where people will be trained. And we look forward to this exciting partnership that we are having. And of course, with JSPH and Anil, I've been involved for many, many years. So now we are, having our foray into digital health and trying to have the digital skills imparted to all the students of public health, School of Public Health, who may be. So we definitely will be happy to talk offline, happy to collaborate with anybody and everybody who is into digital technologies and digital health. I'll start with our guests, and Suresh is coming first up. Suresh has a very good bio sketch, and he has done a lot of things. But Suresh, the first and foremost thing which I liked about your work was the rapid prototyping that you have been doing, and this is very good. And I think we will talk more about it. But few questions which come up, are that is digitization only for the urban population, or is it also for the rural areas? And also the additional question is, what are the other digital technologies which are increasing the outreach?
It's 19 hours.
To the hard to reach population areas? Suresh, please.
Hi, thank you, Jagdish, for the question. And also thank you, Dr. Anil, for the introduction. When you're talking about digitization, let's say you're in urban India. Now you could actually schedule an appointment for a doctor. Perhaps you could actually even get a home visit from a doctor. You would be able to schedule a diagnostic, maybe an appointment. You could probably get your medicines delivered to your home. All these things can actually happen in an urban setting. But if you are in a rural area, even finding a doctor becomes a challenge. So the rest of all these services, you pretty much have to forget about them. Now, this is not only for healthcare. Even if you're talking about let's say e-commerce or even banking, this is pretty much the same situation. Or rather, they've actually found out a creative way to engage with the rural population. So if you would want to order something on Amazon, you could actually go to your local neighborhood shop, and then you could actually access Amazon from there and then order whatever services. So the same with ticketing. You could go to your what you call a ticketing center in a rural area, and you could order or you could book the tickets online. Now the challenge here is the same thing is not happening in healthcare. So healthcare has not yet found a way to engage these intermediaries and then deliver a service in a meaningful way. And unfortunately, it is still a work in progress. Now, if you are looking that as an issue, there are several components to it. One is the regulatory system itself, where at least now in the last few months, I wouldn't say thankfully due to COVID, but because of COVID, government has actually made telemedicine possible. So now you have a rule which allows you to even deliver telemedicine as a service. But then there are other challenges when you are talking about rural healthcare. Now, India at least has some unique challenges in them. Now, India is the only country in the world which actually has 30 official languages. So if you want to deliver healthcare, your medicine is taught in English, but it is practiced in a regional language. Now, that itself is a challenge. You are talking about empowering and training these people. Now, again, it's the same story. Healthcare is a very complex service. You are looking at least 23 specialties. And even if you're looking at 5 conditions in each specialty, you're talking about 100 conditions. Now, screening for these 100 conditions in local languages, where in a country, even dialects change. So even something as simple as fever, you would be able to kind of communicate it in 100 different ways. So that is where training becomes a challenge. And now the third part of it is the devices and the equipment that we actually use. Now, all these equipment, you find it very difficult for them to survive in rural areas. Even something simple as a mobile phone, if you actually look at the specification, you're not supposed to use it beyond 25 degrees or even 30 degrees. It will actually heat up, and probably even simple things like dust would actually kill. So these are the challenges when you're talking about digitization in rural areas. One, the service as healthcare is complicated. Second is the ecosystem, which is very challenging. And the third is the regulatory part. So if you want to sell something, you can fairly quickly sell it because there are not too much regulations around it. But healthcare is a heavily regulated subject. So each and every step has to be approved by the government. So these are some of the challenges that rural ecosystem actually faces. Now, when you are talking about the technologies, obviously these are challenges, and our job as researchers and service providers is to address them. So what can actually help us? Now, the easy answer that everybody is going to say here is going to start with AI, artificial intelligence. And everybody is going to say AI is going to change everything. Now, that is basically the easiest start. But the next question is how? Now, how is AI going to help rural areas? And most of our solutions are going to be hospital based. And in rural areas, you are not going to find a hospital. So the first challenge that we are looking at is something very simple. How do you even register a person? Registering a household. Now, we don't even know how many people are there in this country and how many people or how many households are there in this country. It's very difficult. Aadhaar is there, but it really does not work in a way that we actually want to do. So this is where we are actually trying to bring in AI. When everybody is talking about AI, at least we mean only two things. One is computer vision or image recognition. The second is optimized resource allocation. So when you're talking about image recognition, for registration, you can use facial recognition, which is fairly commonly used. So we are actually extending the same technology for house recognition, facial recognition in rural areas, and even house recognition. We are actually using imaging to identify the type of a house automatically. So we are actually working on algorithm, which if you take a photo, it will tell you what type of house it is. And also the features around it. Is there water logging? Is there garbage around it? What type of what type of wealth status this person actually has? And these are things that we are actually trying to automate. So if you look at the present way of even gathering this data, for something as simple as wealth status, you'll have to ask 20 questions or 30 questions, which is going to take you 20 minutes. And none of this is actually being done in rural areas. So we are actually coming out with algorithms that can actually do it in 20 seconds or 30 seconds. And that is how fast it could actually be. The next step that we are trying to do is even identifying the nutrition status of a person, again using images. Take a image of a person, you'll be able to tell automatically the height, weight, and the BMI of the person. But all these things can actually happen in 20 seconds or 30 seconds. And if you're able to do that, you'll be able to provide customized nutritional interventions at the point of need and with due recognition to what is available in the local environment. So that kind of customization AI can possibly provide. Going forward, once you know this environment that the person is actually living in, you will be able to address communicable diseases much better. Now, water sanitation and hygiene is the most, what you call the indicator for communicable diseases. And in most cases, we don't actually give advice based on the immediate environment. And that is what we are actually even trying to solve using imaging and using computer vision. If you are even able to identify the environment that the person actually lives in, we will be able to provide much better service to the person. Now, the next technology that we are actually looking at is graphic design. And a lot of people wouldn't even possibly understand what graphic design is doing in healthcare. Now, if you look at literally all digital interventions, the biggest decider on if it is going to work or not is the user interface or the user interface design. And this is where we are even trying to address language, which is a real issue on the ground. So we are converting all the questionnaires that are already available, already validated, identifying all the keywords, converting them into icons or animations, and coming out with a completely new user interface which does not have text in it. So that is how we are actually addressing language as an issue. So all our softwares which we are developing does not have text. All you need to do is look at the icons, hit a plus or minus button, and it can actually lead to the next step, which is the differential diagnosis of a disease, or perhaps even further management. So now you have this software which can pull in data as fast as possible using images, which is using AI. The second is using graphic design. You are actually bringing in all the understanding of the signs and symptoms. The next step that we are building is the interventions. So how do you start intervening in real time? So this is where we are thinking augmented reality or AR can actually play a very critical role in conveying the information of intervention to people in real time, but in a way that people can actually see it in their own customized settings and tell them how to do each and every intervention step by step. So if you want me to summarize, the three big technologies that I would actually see would have a big impact on the ground would be AI, but AI is a large, broad area. So more specifically, computer vision, more specifically, resource optimization, graphic design, and the third one would be augmented reality. So these would be the three critical technologies that would actually play a good role on the face of the service. Now, there are a lot of backend technologies, but I guess they would be on the backend side. So thank you for the question. Jagdish, I think you have the...
Jagdish sir, you have to unmute.
So sorry. Yeah, this mic system. Anyway, yeah, Suresh. So it was really good, and I think these technologies definitely do play a lot of role, and we should all collaborate and talk a lot more about it. And the UX part, which you said, is really understated. A lot of people do not realize that the graphic design plays such a big role, and when we talk of the hyped words like AI. We have next panelist, which is Keshav Sakla, and he started with AI at the age of 20. And I liked one thing about him that he says that he is into pragmatic AI, which I really like, because pragmatically applying AI and affordably and being affordable is equally important, because otherwise it will not be adopted. So Keshav, over to you, please. Go ahead.
Thank you. It's a real pleasure to be here with everyone. So as we know, artificial intelligence will have a substantial impact on everything that we care about. It's already making a massive difference to our businesses, organizations, institutions, and to the lives of individual people. It's also true that the job that just one clinician does for just one person is genuinely profound. It's transformational. It doesn't change the world, but it does change that client's world. It means they can live a longer, healthier, and happier life. We may then wonder how we can recreate this positive human impact on a large scale in a cost-effective way. So we synthesize technical and scientific progress, the relevant evidence base, insights from both practitioners and experts, and importantly, user feedback. And the first app that we built was already mentioned, Quit with Better. And can you see my screen? Yeah. So Quit with Better, we've synthesized advances in conversational AI along with the NCSCT and the NICE evidence guidelines for how stop smoking services should be delivered, with the insights and experiences of 200 stop smoking advisors along with their trainers and experts, and client feedback that we've amassed over a decade of providing face-to-face stop smoking services to build Bella. So Bella's your functional equivalent of a stop smoking advisor, and can talk to a client just like a real advisor would talk to a client. And you can see from the kind of screenshots that the conversation is very open. It's free flowing. Bella asks the user questions like, how do you feel? How can you reflect on certain things? And quite key evidence-based techniques like identity change and normative feedback are possible in this context when a user is having this personalized conversation with an expert. And this not only enables us to scale an evidence-based solution, an evidence-based intervention for smoking cessation across a population, but also allows users to have this personalized conversation with Bella, with a trained expert. And it's very important to consider the kind of techniques that human advisors use. They'll try to build rapport with the client to enable successful behavior change. They'll use techniques like I mentioned around normative feedback and identity change. And this happens when you can understand someone and you can respond in a dynamic way to challenges they say they're having or how their week is going to go. And yeah, so this is being used globally. We've got thousands of people have quit smoking with Better globally, and we're always improving this based on user feedback and expert feedback. And one of the key pieces of feedback that we got was users were saying that, oh, okay, it's great, I can talk to a trained expert like Bella, but what about other people who have gone through what I've gone through? What about other people who are also trying to quit smoking? So we've also on Quit with Bellas, there's Bella community, and this is a community of Bella users who can support each other to become smoke-free. And we know from the evidence base and research that peer-to-peer support can really help people achieve their goals. It's being, yeah, as I said, used globally, but here in the UK, it's being used by a number of towns and cities to provide this stop smoking service at scale. And this model allows us to venture into other areas in healthcare. It's not just smoking. Smoking cessation is extremely important. As I said, there's 1 billion smokers around the world. Many don't have access to an evidence-based service. In the UK, we're quite lucky. There's the NHS, but many across the world just don't have that access. And it's also true that many globally don't have the access to an expert when they have a child. 0 to 5 well-being is so important for new parents and guardians. It can be really difficult sometimes to raise a child and navigate some of the challenges. So again, using the model of synthesizing the evidence base of conversational AI, of data from trusted areas and sources, along with insights from experts and user feedback, we can build another robot called Teddy. And Teddy allows you to coach you into better well-being for your child across many different areas. There's, as you can see there, from breast to bottle feeding to emotional well-being to oral health. And again, what's really key here is a user can have this honest, free-flowing, human-like conversation, build rapport, build trust. As you can see from the screenshot, how much weight should my baby be gaining each week? So this is how people talk. It's used quite complex sentiment analysis for an evidence-based, personalized response to come back to the user. And this enables us to scale evidence-based interventions through diverse communities with dynamic needs, and ultimately helps to improve health outcomes for all. Thank you. I think you're still on mute. Yeah.
Yeah. So I think, Keshav, you again underlined the importance of graphic designing, as Suresh said. Thank you for your exciting presentation, and I'm sure that we have to listen more on it. We have the next up is the youngest panelist, Hormuz. Welcome to the board, and you are into AI at a young age, and I read about you, and you're working on the patient mortality models, and which is so relevant in these days. So Hermes, over to you. Please let us know what you have been doing, and how do you think researchers should really take up the progress on the topic of the patient mortality prediction in general, especially in the context of Corona. If you could please talk about it. And second is, if you have any other things which you think that the research should be going that way for AI to solve the healthcare problems, whatever we are talking about. So digital health and AI, as per, in your opinion, how it should be working. Please, Hormuz.
Sure, thank you. Yes, I've created a quick presentation about my research project that I could just share, if that would be fine.
Please.
Yes, so this was a project I worked on with two of my classmates for a class project on predicting mortality in the intensive care unit. So essentially what we are working on is trying to build these ML models to firstly predict the mortality of the patients at the end of their stay in the ICU based on the information we had of from the first 12 hours of admission. And secondly, to identify which features in particular were most helpful for making those predictions. So the first part of this involved collecting the data. So we used this MIMIC-3 critical care data set, which was obtained from MIT's computational physiology lab. And then we excluded certain observations from the data set, certain individuals for different reasons, like newborn babies, which could bias the results in a certain direction, individuals that didn't have any lab data available, and individuals who stayed for less than the 12 hours on which we were collecting the data from to make our prediction. So essentially, we had a total of around 7,500 patients left, somewhat equally divided among the two classes that we were trying to predict of patients who died and those who survived. So we wanted a balance of those two. And then in terms of the features we used, we had a total of 113 features. We had some of the vital signs data, like the heart rate, respiration rate, body temperature, blood pressure, and also some data from the lab measurements, like the glucose level, hemoglobin level, etc. And then we decided to do some feature engineering to see if we could use those original features in the data to generate new features that could enhance the predictive ability of the model. So we did things such as just taking an average of the data across the 12-hour period, as well as also calculating the slope or the trend of how the vital signs changed over time, and also a weighted moving average of the vital signs that would put more emphasis on more recent recordings of the data, which we assumed would have a bigger, greater value in predicting the mortality. And so we started off by splitting the data set into a training and test data set with a 3:1 or 75-25 ratio. And we first created a baseline model, which was just a very simple model of logistic regression, with the only features being the age and the diagnosis. And then we also created these more complicated models that included all the 113 features. So one was logistic regression, SVMs, random forests, and GBM. And we tuned the hyperparameters of these models with the 5-fold cross-validation. And we were able to measure the accuracy of the models, and we could see that there's been a huge improvement in the accuracy of all 4 of the models compared to what the baseline model was. Yeah, here is just the diagram of the ROC curves showing how the area under the curve, which represents the accuracy of the model, is greatly improved for these 4 sophisticated models compared to the earlier baseline model. And we were also able to identify the most predictive features from the model. In the case of random forests, they identified the most important features as the age of the patient, which makes a lot of sense for predicting mortality, as well as blood urea nitrogen, which is an interesting observation that it's much more predictive in this model than all the others. And then from our logistic regression model, we were able to find insights such as that platelet count was negatively correlated with mortality, cirrhosis and age were positively correlated. So in conclusion, we note that our models were able to make significant improvements in accuracy based on the engineered features. And secondly, we were able to get insights on which specific features were helpful for making these predictions, such as age, blood urea nitrogen, and platelet count and cirrhosis. And yeah, Jagdish, would you be able to repeat your questions?
Well, I just was about, whether you have any other suggestions for the people who are trying to apply AI for the healthcare problems. In general, how the AI should be applied. So the applied artificial intelligence for the digital health programs.
Yeah, so I think one a piece of advice that I think would be very helpful is to focus a lot of the time also not just on building the models, but on cleaning up the data and doing the feature engineering. Because with any sort of data, if it's not correctly cleaned up or removed certain observations or features, that can lead to your model not being able to make the right correlations. So putting a lot of emphasis on those steps that are much less exciting than building the models definitely pays off. Additionally, I think being wary of like the class imbalances in the data is really helpful for any sort of project in AI, especially when it comes to medicine. For example, I once worked on a project with brain tumor medical image segmentation. And there, since most of the pixels in the data are non-tumorous rather than tumorous, that can really prevent your model from successfully being able to identify something, because you could get 98% accuracy just by predicting everything as one outcome if 98% of the data happens to be that way. So I think balancing that type of data is helpful. Making sure you have a large enough sample size so that you avoid overfitting when your models just fit perfectly to the data you have, but don't generalize well to broader data. So that's very important. And I think lastly, I would put a lot of emphasis on being able to consult with people who are specialized in the domain of medicine, even if they don't have as much knowledge of AI or machine learning specifically, because sometimes there can be cases where the models are picking up things that don't really have anything of medical value or anything to do with medicine. And having an expert to be able to guide you on those insights and identify what has medical validity and what does not is always really helpful in machine learning.
Thanks, Ormaz. I think you have really brought up some valid points, and the domain knowledge and the data accuracy, and these are really vital points. When we are trying to adopt the new technologies. And who better than our next panelist, who is Akshay? He's the onco radiologist, and he is deeply interested in AI, and he is utilizing it. And so, Akshay, the question to you is, how the AI can be actually utilized in oncoradiology and the personalized radiology, in your opinion? Akshay, please.
Hi, thanks a lot. So, I'll be focusing on AI and radiology. And of course, diagnostic radiology is now pretty much the first step for any acute or chronic disease management. But the main roadblock we have is actually lack of radiologists, be it developing countries like India or developed countries. There are just not enough radiologists to be able to give enough time to sufficiently and adequately read all the reports. And of course, then there is lack of good radiologists, but we won't go into that right now. And that is where AI should be able to help us. So even in countries like UK, where the NHS is widespread, there are hospitals which have backlogs of 30,000, 25,000 cases unreported, and very long turnaround time. So sometimes X-rays take over 1.5 months to report, and that is really not acceptable. So I think the main sort of focus of AI will be firstly to replace the radiologists for basic imaging studies, which should be like a medium-term goal, and perhaps augment the radiologists in interpreting more complex studies, which will be, I think, a more longer-term goal. And every month or pretty much every week, actually, we will, at least in radiology, see these fantastic studies talking of how AI catches lung cancer early or catches breast cancer or COVID early. But, that is more of hope, a hype than hope right now. And in fact, the American College of Radiology and the Radiology Society of North America just earlier this month came up with this statement that AI algorithms aren't close to being safe enough to replace radiologists right now. And that's a very strongly worded statement, right? They're not even close to being safe enough. And so I think sort of bridging this gap between what is the hope and what is the hype is the key. So how do we do that? I think the easiest sort of goal or achievable target would be to able to identify normal versus abnormal. I would say 70% of radiology investigations are normal, particularly the X-rays. And this is, I'm sure, the focus of AI right now also is identifying normal chest X-rays and normal bone X-rays for that matter. This is the main focus right now, and hopefully this is where the first thing we will achieve. Then the focus will probably shift to identifying common abnormals or specific sort of niche areas or niche questions which AI can answer. So for example, if the chest X-ray shows presence of fluid in the lungs or a cavity, then perhaps AI can say that this is likely to be TB and not something else. So this is probably the next step. Specific scenarios like maybe a DEXA scan, the AI can help in identifying whether there's osteoporosis or not. So these are things where AI can easily sort of augment or replace the radiologists. But I think the next 3 steps are not as easy to do. So when I say replacing the radiologist in totality, what AI might do is in the future replace the radiologist where there is no radiologist. Of course, that is what we want it to do or need it to do. But replacing it, the radiologist in a place where he or she exists is not that easy. That will require a lot of more evidence to show that the AI is as good as the radiologist and also not doing any harm to the patient. And for that, we need more clinical evidence and not just data-specific evidence. And then the next step probably will come when the AI software actually gives complete reports. Like the sci-fi movies, you scan a patient and out comes the report, it goes to the referring physician, and essentially there is no radiologist in the scan at all. So it's like imaging without images, Can that happen? I hope that it can happen, but I doubt it will. But what might be like the final sort of outcome is that it will augment the radiologist. So be it an average radiologist who's looking at a study which looks more complex than he or she can interpret, go to the AI, or a very specific, subspecialty trained radiologist, but still maybe trying to look at something with the naked eye cannot really interpret well. That is where the AI will be able to augment the radiologist. And let's see how do we achieve this potential. And the most important thing, and some of these have been alluded to in the previous talks, the most important thing right now is to have validation data sets. So most of the data sets, I think 90 to 95% of what is published is based only on a single institutional data set. And it is often not valid when applied in the real world. So 40,000 chest X-rays on American patients, when applied to the real world in India, the data set is no longer valid. And I think it's important that all AI studies have this validation data set to prove that it really is delivering on what it proves and it is not overfitting. Once that validation data set is there, then these promising AI software need to be really used in the real world, used in hospitals and used in clinical trials. So I've seen by now what has happened with the COVID scenario and, hydroxychloroquine, how it's risen and fallen. So the main thing is that we need trials to really show where AI works and where it doesn't work. And once, for example, if we are able to show that perhaps AI works for identifying normal X-rays at least, then we need also easy integration into existing workflows. So the software is great, but if we are not able to use the software because we are using a system vendor which is like entrenched in our systems, be it GE, be it Siemens, and the AI software provider is not able to integrate well with the workflow, then we cannot really do a lot with that software. So this is also needed. And for all of this, I think we need more crosstalk. Right now, what happens is the AI companies come to the radiologist and they just ask for data. They don't ask for questions. They don't ask for what should we study. The first demand is, can I have 40,000 X-rays? So we need more crosstalk about what are the right questions to ask and what is the methodology we need to use to be able to answer these questions in a scientific scenario or in a clinical scenario. And I want to just touch on how it specifically will augment the oncoradiologist, because that's my niche. So, and a CT scan or an MRI, for example, is basically pixel level information. And most of the times, what we see is what the human eye can interpret. But probably there's a lot more in this pixel that we cannot really catch with our naked eye. And that is where we hope that AI can at least help and take us to the next level. We can have tools like CT texture analysis, for example, to be able to differentiate malignancies from benign lesions. And eventually, hopefully, we might come to a day where instead of really taking tissue and looking at it under a microscope, we will do a virtual biopsy, essentially do a scan, run the AI software, and be able to tell what is the tumor, what are the genetic mutations involved, and what can be the drug used for treating this tumor. So this is the next level. And then the final level is whether it can actually predict outcomes. When we see this particular imaging finding, does it mean that the patient needs more aggressive management, more aggressive treatment versus another imaging finding, which can be managed more conservatively? So these are the three foci of research for oncoradiology. So in conclusion, a lot of potential, but right now huge gaps. We really need to fill the gaps. It will take time. We have to be patient. But the main thing is that it needs to go beyond the labs, into the hospitals, into large scale setups, and real world data and clinical trials is the need of the hour. Thanks a lot.
Thanks, Akshay, for the very good presentation. There was a joke some time back in AI world that radiologists will go out of job first up, with the AI coming in and they'll be replacing all. But as Hormuz put before you, this needs more of the domain knowledge than just the technology to do the job. So we need more of radiologists and better of AI to do a better job for humanity. Thanks, Akshay. We have next one coming up is the Mayank. He runs a hospital, so he's well positioned after Hormuz and Akshay to comment on how much he needs and how the digital health can be benefited with the AI, and with the health technologies can really help the healthcare delivery in the hospital. Mayank, please.
Hi, Jagdish. Thank you for the introduction. So Medipulse has been there for last 6 years, and I joined as an intern, and now I am managing the entire setup. I work as a director strategy of the hospital and basically decide how to get into the digitization space and the digital space. So I think I had a very interesting incident. So it was 2014 and India was in the process of going paperless. That paperless moment was there. And I went to a government setup where I met an official and I asked him, oh, wow, are you guys going paperless? And then he was like, yeah, we are going paperless. And I was like, okay, can you tell me the process? Okay. So he told me that, my boss sits in the next room and this is the document that I have. We generally scan it, and scan it and send it to him via email. He sees the email, but he doesn't like going reading things on screen, and he takes a printout in that room. And then I realized, okay, this is the digital boom that is happening all over India. And if you go to any Sarkari office or any government office, this was the typical way people used to work, was scan documents and then take a printout again. So, and then, it was a very, very long process for me to convince people that this is not how digitization happens. Going paperless completely is the real work. 1 year down the line, 2 years down the line, we started, getting like a lot of, we implemented a telemedicine system and realized there were a lot of patients coming for telemedicine. And, but the entire user experience was not good. And the doctors were like really fed up when that entire WhatsApp boom came in. And every doctor used to have a WhatsApp status as no WhatsApp consultation, please. 2 years down the line, the pandemic happened. And every doctor now has a status, only WhatsApp consultation. So I think the last 6 years have transformed. It's not just the technology that has been transformed. It's the way people have the perception towards technology that has been transformed. So there was a time when we used to give printout lab reports and people used to come ask about, can you send an email or can you tell us telephonically? And now we have reached a stage where people don't want email, people don't want scans. Everyone wants a WhatsApp integrated report. So as soon as the report comes out, can you send it on WhatsApp? So this is the first thing I asked my software vendor, can you integrate WhatsApp to the existing hospital information system? Second, very interesting thing that has happened is the rise of wearables. So Holter as a technology was, I don't know, every cardiologist used to prescribe Holter. Now we have Apple Watches and different kinds of wearable that are available that is collecting so much data. But there are two problems. First is people don't know how to interpret the data. Second is clinicians who were trained in 60s, 70s, 80s, 90s, or early 2000s have no idea what wearable exactly are. So I remember my mother is an athlete, and she happened to have a resting heart rate of 39 beats per minute, and it showed us a notification that, you know, this is 39 beats per minute is really less. And then I took a screenshot, sent it to my cardiologist, and he was shocked. He the first thing he asked was, who is she? Is she a mom? I was like, yeah. And then the second thing was, does she happen to be an athlete? And I told him yes. And then he realized, okay, this is the power of wearables. So generally doctors are, the way medical schools are, we are taught to write medicines. We are not taught to write wearables. So I think we are in a very interesting phase where the clinicians are moving towards the preventive side and using all the technology that they can at their disposal to make sure evidence-based medicine is practiced at best. Integration of packs, using of AI is definitely there, but very interesting case study that I personally am a big believer of is garbage in, garbage out. The data that is entered has to be perfect in order to make the best use of it. So all AI models, all predictions, all machine learning algorithms will fail if the data entry is not correct. And India as a country, the data entry is the biggest problem. As pointed out by different people, graphic representation, multilingual support in softwares is a big yes. And that is something which is a current issue where we are working on, where we are asking the software providers, okay, can you share this in Hindi? Can these forms be translated into Hindi? So I think from a technology forefront, it is a very interesting phase. I think technology used to exist even 10 years ago, but the way people perceive, the perception towards technology has changed. And I think the pandemic has been a big catalyst. Going forward, I think GE, Siemens, and Philips might be replaced with Apple, Amazon, Facebook, and Google. The kind of work they are doing in AI and health is amazing. I think Amazon is doing a lot on the service side, on the AWS side, which is very interesting breakthrough. And Apple has collaborated with Stanford. The healthcare research they are working on is going out. I think it will give out really good results. So I think overall 2 years, 3 years down the line, we will be moving from actual paperless to digital, and from digital to digitize. And that is going to be a very interesting phase. We are in the process of transforming our MRDs, medical records. We still have a lot of paperwork. The government overall has changed its philosophy. Earlier, any insurance claim, there used to be a 3 set of hard copies that used to be sent to a government organization. And then government said, okay, let's scan it and then you can upload it on a portal. So there was a portal that was designed. Then came the ICD coding in picture, the international coding for diseases came in picture. So I think government on large level is also realizing. Then you have the health stack that has come up recently, 1 year ago, by the government of India and Ministry of Health and Family Welfare, which is working on interoperability of softwares, how to reduce paperwork, how to get more of data. But again, garbage in, garbage out. That's the crux. Thank you so much.
Thanks, Mayank. The most important thing is administrators like you are realizing the potential of digital technologies, and that's what matters, because once you realize it makes sense to you, then even the doctors who have been trained in 60s and 70s, and my father happens to be one, and they all eventually start getting into that because they see the potential, they see the outcome. It's all outcome based scenarios. So thanks, Mayank, for all these insights, and really happy to hear all that. I will hand it over to Anil for introducing Adarsha, our special guest who has joined us. Thankfully joined us at the last minute, and then from there on, my friend Greg will take over the moderator's duties. Thank you, and over to you, Anil, please.
Thank you, Jagdish. Adarsh. I'd like to introduce Adarsh. He is the CEO of Ayush Devices in Mumbai. And the company has come out of IIT. And he has been very popular on your NDTV, Indian TV, and he's doing a lot of projects on telemedicine, working with the Indian Telemedicine Association, which is doing wonderful work. And he works very closely with the president of Indian Telemedicine Association in Jaipur. And also he works with lots of doctors in Mumbai and around the country. So he has developed a digitized stethoscope and lots of other devices. He has been winner of lots of awards by Public Health Foundation of India in Gandhinagar, MIT, Stanford, and these are few names actually. And he's very talented, and it was very difficult to get hold of him. And here is Adarsh. And Adarsh, this is a very brief introduction about you, but if you could share with us how are you doing with your newly developed stethoscope, and how is it being used, and what role are you playing in COVID-19 and promoting your talent?
Adarsh, is he here?
He was there.
Yeah,
I think
yeah.
so. Anyway, I just want to have one quick question for Yamini, and she has less than 2 minutes. I think it's very important to bring up these interns to speak about their experience and what message they could give to our undergrad students at Poornima University, that why this internship is valuable. So Yamini, could you please tell us how has been your experience with Greg for last 1 year and with these webinars, and what is your message to our BPH students at Poornima University regarding your internship, and do you recommend that they do these kind of internships?
Sure. Thank you so much for having me. I enjoyed hearing from everyone so far, and I was able to learn a lot, which is definitely great. So through this internship, I was actually working with Dr. Fant last summer a lot, especially. And then throughout the year, also, I've been working on developing a report on blindness prevention in India and how to continue making that and using other third world countries' models to help this with India too. So I have actually very much enjoyed this internship, and I've learned a lot from it, I believe. I've gotten to interact with a lot of amazing people, especially including everyone on these panelists who just have a lot of experience in the healthcare field, which is something that I'm super interested in as well. So my message to, I guess, all this undergrad students about this internship would be, the biggest thing I think is like, don't be afraid to ask questions and to keep learning, because this is something that, you know, we're still kind of trying to figure out, and we get to like interact with a lot of people with a lot of experience and a lot of knowledge in the healthcare field, which is something that, you know, our new generation and the next generation is going to have to continue afterwards as well. And so, you know, not being afraid to ask questions and not being afraid to, you know, it's okay to do something wrong, you know, you can fix it afterwards, is one of the biggest things. And I think that's one of the hardest things for me too, because I do tend to be shy sometimes, and it'll be hard for me to like put myself out there. But the more you do that and the more you know, get out and keep reaching out, is the only way to, you know, succeed in this field, and the only way to be able to help anyone around the world.
Thank you so much, Yamini. Adarsh is back. He has a connectivity issue. Imagine it's the technology. He develops technology, but he's in his village, so he is in and out. So I think without losing time, Adarsh, could you tell us about your project, about the stethoscope? We had done your introduction. Now, could you just quickly share with us before we lose you?
Sure. Thank you very much, Dr. Anil, for inviting for the event. So quickly, I will just share my slides. Yeah. So let's start with the case. 26-year-old male, teacher by profession from UP, comes to a hospital in Mumbai, and he has swelling in his limbs.
Adarsh, could you please turn on the slideshow so that it's full screen?
Okay, okay, sure. Yeah, is this better? Is this better?
Yeah.
Yes. Yes.
Thank you.
Okay, great. Yeah. So, he came to this Mumbai hospital with these symptoms. And, they could see his ECG was abnormal and X-ray was again abnormal. So they could identify there is a hole in his heart. So he's having a ventricular septal defect. And if someone had placed a stent on his heart, they could listen to a murmur, which was missed. That is the reason he was misdiagnosed in the early stage. And we look overall, there are around 2 lakh children like this born every year. And 1/5 of them require early intervention. But it's very difficult in India because we have around 4,000 cardiologists and the requirement is 88,000 cardiologists. We don't have CT or MRI in the villages. That is why we have developed a module which we can attach to a conventional stethoscope so that the heart and lung sounds can be amplified, shared, as well as analyzed. So we use signal processing techniques to identify the murmurs, and also we use AI to classify whether it is normal or abnormal. So this is how it works. We have a mobile app. We take patient data and then we take the sounds as well. So these sounds are uploaded to the cloud and we process this and we give back the result. So you could see that the first graph, that is a normal heart sound. And the second one, it's from a 6-year-old boy who was having a hole in his heart. So there are murmurs in his heart. And that you can identify using signal processing and machine learning techniques. So we have deployed this in a couple of primary health centers. This is in Gujarat, in Maharashtra as well. And already a lot of telemedicine companies who are using this device. So they use the device to collect the data, as well as they use our services, cloud services, to identify the abnormalities. And even during COVID-19, we're very happy to share that we are able to do a bit. Our device is used to keep a safe distance from the patient so that the infection is reduced. And we are getting very positive response. And a lot of doctors, pediatricians, they're able to use the device to capture the data from the patient, keeping a safe distance. And already we are working on algorithms which will identify if there is any crackling sound or if there is any wheezing sound. And these are the sounds are heard when there is any pneumonia in the COVID patients. So this is what we are doing. And we are supported by IIT Bombay, BIRAC, Department of Science and Technology, Millennium Alliance. So with all this support, we could reach to this stage. Yeah, and a couple of coverages and everything. So overall around 1,600 units are deployed in India, all over India. So this is what we are doing. Thank you.
Thank you very much, Adarsh. This is our strength we feel at JSPH, and wherever I have worked and also worked with Jagdish, we like to go to difficult places, forgotten places, and it's very important for us, these difficulties, because where Adarsh is today, he's in his village because of the lockdown and other issues, and we need to bring all these technology in these villages, and only by having these kind of panels, having this exhibited, going in the news, things will change in every country on this planet, actually. So I think this is very important for us. Innovative work, doing wonderful work, coming from down south with limited resources, and you've done wonderful. So thank you so much, and we're so honored to have you. I would like to invite our friend Greg Fant to take over as a moderator. It's all yours, Greg.
And thank you, Anil, and thank you everyone for being here. I am learning so much this morning for me, and it's very exciting to be here. The first question that I have, or the first person that I get to talk with is Vibha. And I've known Vibha for a long, her and her husband for such a long time. And it's really good to see you. And as I'm reading your bio, I see that, you're no longer teaching public health, but actually doing something else exciting as well. And so I just wonder, from your new position, you know, as a scientist and certainly as a leader in health technology assessment.
Yeah.
Please share with us, please share with me, because I don't know, what exactly is health technology assessment, and how do you see health technology assessment being useful in healthcare organizations there in Jaipur specifically, but perhaps in India a bit more broad?
Thank you, Greg. Thank you. Thank you for giving me the chance. Actually, it is not new for the developed world or the Western world, but it's quite new for developing countries like India. The Department of DHR has started the HTA, or the Health Technology Assessment Department, very recently in 2017 in India. Before going to health technology assessment, I would like to tell you what is technology, health technology in terms of HTA. For all of you who are working in AI or technologies, technology can be device or a technique or equipment. But for HTA, it can be any drug, vaccine, or it can be any immunization program or any public health program. And now coming to what is health technology assessment. Technology assessment is actually assessing the impact or the process of the technology going on. And these can be assessed at various levels. It can be assessed at early stage of development. It can be assessed at the experimental level or at the level of clinical trials when the technology is established, or even technology assessment can be done for the obsolete or outmoded technologies, just to demonstrate whether it is ineffective or harmful. Now coming to what is HTA or what is health technology assessment. It is a systematic evaluation of properties, effects, and impacts of health technology. It can address direct as well as indirect or unintended consequences of technology. It actually, it is a field of scientific research which can inform policy and clinical decision making around the introduction of and the diffusion of health technology. And it covers 9 domains, different domains. These are health problem and the current use of technology, technical characteristics of new technology, even the safety assessment, clinical effectiveness of technology, economic evaluation in terms of CEA, that is cost effective analysis, ethical analysis, organizational aspect, and even the legal aspect. It can be done, health technology assessment can be done under all these domains, or few of them can be used for assessment of any technology. And now, Greg, coming to your second question, how it can be useful in healthcare digitalization. What is digitalization and what it is in healthcare? It means digital information of a patient or a client that can be shared among all the parties that uses it. So digitalization in healthcare, it can be divided into 3 waves. The first wave of digitalization consists of electronic medical records, pictures, communication system, laboratory systems. Then the second wave of digitalization included utilization of the collected data as well as the citizen involvement. That was the example for that is mHealth programs or mHealth applications, what we are using nowadays. And the third wave of digitalization, the whole webinar is based on that. I feel so that is decision support, guidance, and process based on existing data. And it includes novel solutions like AI and machine learning in healthcare. So coming back to what the HTA can do in digitalization. We are using technologies at all the levels, all 3 waves. But the assessment of the technology is very much important because of the safety, safety of the data which a patient is giving to us or a client is giving to us. So in WHO Global Survey of e-health in 2015 revealed that 73% of the countries doesn't have any system in a place to verify the quality, safety, and reliability of mHealth program or mHealth application. But recently, in 2019, the several new health policy acts have been implemented, but that too in context of the developed world only. And now coming to the Digi HTA or digital HTA, it can usually the people are using mini HTA, what is using only 4 domains of the basic HTA program for the assessment of digital. But it's more than that, because it lacks the important elements that are essential for the health service. And many of the programs have suggested to include HTA framework cover key assessment and should include at least domains. It should include company information, product information, cost, effectiveness, clinical safety, technical stability, usability and accessibility, interoperability, data security and protection, and last and not the least, AI and robotics. The HTA, basic conventional HTA, differs from the HTA of digital health solution. The value of digital health solution does not only depend on the clinical and the economic aspect, which we usually do for the other technologies. It also includes perceived benefits for healthcare managers, willingness to use by end user, and finally, the healthcare system's capacity to benefit from the innovation. This is what HTA can help in the safety, and digital health solutions should be determined to by the incremental advantage it can deliver compared to the current standard of care, what we are getting.
That's very, very helpful. Thank you. I did not realize. So I appreciate that you shared with me, with all of us, thinking about really almost evaluating healthcare technologies in various domains, such as the electronic medical record, the mHealth applications, and decision support. That's really, really helpful. Thank you, Vibha.
Thank you, Greg.
Next is Sujay. And I'm very pleased to meet you. This is our first time.
Hello.
And as I was reading your bio, I see that you are just a scientific leader in connected health and innovation. And so I think from that context, could you share with us how might artificial intelligence improve healthcare access? That's certainly the first question. And then the second question could be, how might digital health help transform rural public health? And that's really a big area of interest for JSPH. Seju, please.
Thanks, Greg. So before I started working in artificial intelligence, I think the first thing that I was doing for a while was trying to come up with a model of care delivery in a rural, underserved area. And I think one of the first ways in which I saw technology improve healthcare access there was point of care diagnostics. So that's a good analogy to understand like how AI might be able to help. So we were working in an area that was endemic for, actually hyper-endemic for malaria. And prior to any point of care technologies, the way you would diagnose malaria would be to have somebody go to the village to get a blood smear, and then have that blood smear, which is a glass slide, a fragile thing. You have to get it transported to a lab where you might have a pathologist who can look at it and basically confirm whether malaria existed or not. When point of care diagnostics came in, I mean, we eliminated one person in that whole chain. Now, you could not only do it in the village, even getting the report back to the patient from the lab was a step in the logistics that you could cut out completely. So just extending that to what advances we are seeing in artificial intelligence today, a lot of my previous speakers here today alluded to how computer vision is one of the most promising areas as of today. And really why computer vision is so promising is because fields such as radiology have been digitized the most of all medical specialties. So that's why they're the lowest hanging fruits in terms of acquiring data that you could apply machine learning to. But that is not to say that other fields cannot catch up and digitize in ways that are very, very useful in terms of extending what care you're able to provide. For instance, today in the most rural of areas, and what is rural is really dependent on the context. If you're looking for an internist, a rural area really has to be something remote. But if you're looking for a spine surgeon, you might be living in a reasonably well-equipped suburb, but still not have access to that kind of specialist. So it's relative in that way. And so for those kind of applications, say radiological applications, and now increasingly a lot of pathology applications. So let's say somebody has a spine condition that you're not sure if it needs surgery or not. Well, now today, you would have to ask that patient to go and first have a referral consultation with an expert in an urban area, wherever this expert resides. And then like that evaluation involves this person like making arrangements to stay there, come back. Often it's cost prohibitive for people to do something like that. But now, if you eliminate the need for a person to do that triage, so a triage is a relatively low stakes decision. Like all you're basing off of that is whether this person should go and see a specialist or not. So for such kind of applications, you can now imagine like a whole network of satellite imaging centers or path labs where all you need is a technologist who can help the patient get that imaging modality completed and the imaging process completed. And then you can have a machine learning based computer vision technology, basically, which just says, okay, this person has something that looks a lot like a spine condition that needs surgery. A simple classification, and it could even have some degree of error, but we have the capacity to absorb that error because now you're saving this person a lot of time and money, which can be very critical in a place like India, especially where like the estimates are that 60% of people go below poverty line once they experience a catastrophic health expense. And given the kind of health expenses involved there, you could save people a lot of money. And secondly, by eliminating the need for an expert like a radiologist to do the first pass at looking at this image, you are now lowering the cost of the overhead cost of operating that enterprise. And we've seen those kinds of solutions elsewhere in many different ways. I mean, today, 4G internet has penetrated the remotest corners of India at a level that we never imagined would be real 10 years ago. So I see that in radiology, in pathology, there's a lot of potential for computer vision to help with cancer screening, to help with trauma detection, to help with referrals. And now, like in terms of like healthcare access, if you move away from rural areas, like I said, it's relative, right? So one of the solutions that we had been working on was for epilepsy. And the analogy to that I always think about is the idea of task shifting that we have in public health. So task shifting is this idea where traditionally something that you would need a specialist doctor for, you try and like lend a part of that, a modularized part of that skill set, a packet of that to someone who is a capable individual in that community. Often we call them community health workers. So one of the things that I was involved a lot in trying to come up with a community health worker based model to screen people for high blood pressure and then put them on regular treatment. Now we were working with a population that didn't have high levels of literacy to understand what a condition with no symptom at all, such as hypertension, means, and like why should they be taking medications every day to deal with that. So the biggest challenge there is like you cannot explain complex ideas beyond a point when you're trying to task shift to a person with limited literacy. But on the other hand, if like what they're essentially trying to do is follow a complex decision-making process and arrive at one of like a few conclusions. It's like put this person on the treatment that you have been advised to give, or do nothing, or have them come to an urban clinic and get seen by a primary care physician. So in the realm of epilepsy, the analogous thing, and this is actually for the United States, is that you don't have a lot of epileptologists in rural areas. There are about a good 20 or so medications that can be used to treat epilepsy. But the average primary care physician usually is familiar with about one or two. So what we were trying to do was, like, you have a primary care physician who is more likely to be present in rural areas, but they're not familiar too deeply with epilepsy treatment, as many primary care physicians will tell you. It's not something that they see too commonly enough to know too much about it. So for a patient, what it means is now they have to take leave from work, plan a trip to a very nice urban area, with incur a lot of expense to just get a follow-up visit. And epilepsy is a lifelong condition. So what we tried to build was pattern recognition of treatment plans in epilepsy, which after the initial few iterations tend to be very static in many ways. And you could now help a primary care doc here to arrive at a decision that's relatively closer to what a person with more advanced training, such as the epileptologist, would have done, and allows them to give greater care to the same patient than they would otherwise have been able to do. So that's the way I feel like healthcare access can see promising changes with artificial intelligence coming in. Thanks.
That is very, very helpful. Thank you, Sujay. I can really see in your examples how you're trying to show us how digital technologies can actually come right into the air, as you said, the point of care, and bringing it to that level, and perhaps making it easier for people who have some of these chronic conditions, like the one that you just mentioned, how to still function and still have access. And that's really a helpful description. Thank you.
Thank you.
Sally, this is my first time meeting you as well, so hello. And Anil has spoken to me about you for such a long time, and as I'm looking at your bio, it just really I have so much just to learn from you, right, about putting both public health and development together. And I can see, that there may be opportunities where this is really possible, where some of the burdens of disease that we frequently see in public health, perhaps some environmental health issues, perhaps some health system planning can really be informed by AI and big data. So perhaps you could share with us, what do you think some of the major opportunities and risks are for the use of AI and big data in public health? So certainly that's the initial question. And then the follow-up question could be, what are some useful examples that we can all just have some reference point for as we go forward? So Sally.
Good, thank you. And thank you for that kind introduction. Much has been said already, and especially about how we can better use AI to improve health services, the quality and efficiency of those. So I won't touch upon that. We medical epidemiologists are very much more interested in population health surveillance. So I'd like to take it up a level to talk a little bit about mostly surveillance. The health service applications of AI are much easier to monetize and commercialize, particularly in fee-for-service healthcare delivery systems. But surveillance is not so easy to monetize because it's very much a public function. And by the way, those who haven't thought about surveillance for a while, it is defined as the ongoing systematic collection, analysis, and interpretation of data, which should also be closely integrated with the timely dissemination and use of the data for preventing and controlling disease and injury. So it's a natural for big data. And I think a natural for AI, particularly because of the potential to use heterogeneous data sources, non-traditional data sources. So much of surveillance has been facility-based in the past, and really very much, or sentinel surveillance sites where there's active surveillance. There's a huge opportunity to really bring that up a level and improve surveillance findings and surveillance. I think the AI is perfectly well suited to help with aberration detection. So you can go through massive data sets, scanning, kind of rich text data and other sources to pick up any kind of anomalous pattern or events, and which is very much the essence of surveillance. So it's, as I say, it's a natural. It's always going to be a bit tricky, as several presenters have mentioned, to distinguish the signal you want to detect from the background noise. But I think there are some great opportunities. So that, and as someone else pointed out, that there's often going to be a need for expert review and validation of things that are picked up using AI. But still, I think the potential is huge. And another couple of points I'd like to make about surveillance are that we've traditionally done disease by disease surveillance. Our Centers for Disease Control in the US, for example, has what I have rather nastily referred to as vanity surveillance programs, where anybody responsible for a disease loves very much to collect and master the data sets about that, and build their little empires. But I think there's a huge opportunity with AI to create more integrated, real, true public health surveillance instead of disease by disease surveillance. So the traditional outbreak detection is often based on data from clinicians and laboratories, generally relayed days or even weeks, maybe months after the event. And AI shows huge ability to really make it real time, and then potentially save lots of lives by detecting outbreaks more earlier, and detecting new risk factors much earlier. And then the last point I'd like to make about surveillance is that it's particularly appealing for developing countries. Many developing countries don't have those traditional surveillance systems set up. They don't have sentinel surveillance sites and relay of data. So they could potentially leapfrog and get state-of-the-art, real-time integrated public health surveillance, because they won't be dealing with the baggage of the legacy traditional disease by disease surveillance systems. They could take it, and they could show the rest of the world how to really do this properly. And so I think it's quite appealing. I think it's one of those settings in which the developing countries can really establish the state of the art and make it happen. Some of the risks are, everybody loves to whine about ethics by, kind of the privacy, security, confidentiality issues. You can tell I'm a little bratty about that. I'm a militant data sharer, and I think we can help people understand that privacy and ethical concerns should not be used as a smokescreen to help people hog their data. Academicians, let's be bratty for a minute. Academicians often like to hide their data, and will use privacy, security, and confidentiality as reasons to fail to share it. But I think one thing I would like to point out is that there are public health ethics too, and failure to use existing data and analyze it to save lives is a breach of ethics. So I think we need to turn it around a little bit and understand that that there's plenty of data out there that would allow us to detect undetected diseases and problems, and undetected risk factors, and we could save lives with the data that's already out there. And to fail to do that is the real breach of ethics. Lots of guidance. The European General Data Protection Regulation, the GDPR, is a place we can go and understand really how to responsibly use data. And there are the other reality is that many of the scary restrictions of the GDPR and other codes, other legislation, are really mostly about private health and not about public health. So there are protections, and there is recognition that we have a responsibility as public health people to pool, analyze, while protecting individual rights. So another risk, I think, is just that privatization. That, you know, there's a risk that public health agencies and professionals will fail to really reap the benefits of AI, and in order to improve population health, because of the fact that governments are often slow to embrace innovations, and the tools are often being applied exclusively for paying clients by commercial entities right now. And we need to figure out a way to, and you know, most dramatically to affect consumer behavior and voting behavior. And, you know, we need to make sure that we can really leverage the state of the art for good. And quick examples, you know, I will touch upon them only lightly. Everybody has probably heard of GFIN, or the Global Public Health Intelligence Network, which was developed by Canada's Public Health Agency, and is part of the World Health Organization's GORN, or the Global Outbreak Alert and Response Network. They're doing a lot of really interesting things. It's an early warning system for disease outbreaks, contaminated food and water, bioterrorism, chemical exposures, you know, toxins, natural disasters, whatever. It does everything, and it is global. So it's quite an interesting example. But it uses event-based surveillance, scans multiple sources. It scans electronic discussion forums and websites and newspapers and news reports, and they've even done a little bit of scanning of SMS data, and they've been able to turn up really important information. The influenza control is a really good example, in that Google Flu Trends has developed one of the first web-based tools to monitor influenza activity in real time. Obviously, is also being done for coronavirus right now, though we've not really seen the results of that just yet. But we need to make sure public health agencies are accessing and using those data. There's an interesting example of detecting foodborne illness. The Chicago Department of Public Health has used programs to scan social media posts that might indicate, you know, hotspots for foodborne illness, largely restaurant reviews, and that's been a powerful way to you know, to kind of avert morbidity and potential mortality by detecting and solving those problems. Sri Lanka has done some really nice work with animal health, using mobile phone data and tracking that to in agricultural data sets, and to track the transmission dynamics of animal disease, which we know from the coronavirus, as well as SARS and MERS and Ebola, are very much linked to animal health. So a more holistic approach to health. A really interesting, if not scary, example is from Blue Dot, which is a Canadian firm that has used machine learning and natural language processing to analyze data, all kinds of data. But they have, you know, they sell their data to clients, or their findings to clients. So it's monetized, but they successfully predicted the Zika outbreak in Florida 6 months before it was detected by authorities, and they also detected the COVID-19 outbreak before it was officially declared. But because they make those data available to paying clients, it's a little tricky. We probably missed an opportunity to save some lives with that. there's some ethical issues. So cholera and malaria, Bangladesh has done some great things with using satellite imaging and ocean monitoring data and remote sensing of various kinds to predict cholera outbreaks, which they've done at least on one occasion rather dramatically. And then a lot of folks have used similar kinds of data to predict malaria outbreaks in Africa. People have already talked a little bit about some of the chronic disease things, but I think there's a big opportunity with clinical and socio-behavioral data from wearable devices to really help people, and to have them develop some remedial interventions, lifestyle changes, et cetera, to be able to save lives for some of the chronic diseases, including cardiovascular disease, obesity, diabetes. We are just beginning. So I guess, and although you didn't really ask me to identify interventions or recommendations, I think the one thing is we need to invest wisely, make sure that we get the best innovators and the smartest innovations and really apply them for the public good and not just the private good. We need to communicate very clearly about what we're doing with the data to make sure that people understand that, although they may be free to opt out of sharing their health data, that will in fact disable efforts to save their lives and save the lives of their broader communities. And make sure that we, protect the public trust so that people understand and that we celebrate moments when we actually save lives due to public health surveillance. And then the last thing is we just need to get moving, invest and get busy, saving lives and saving money with AI in public health.
Sally, excellent. There's so much just a rich conversation. Thank you. And really one that is very appropriate for PU and for JSPH and for our mobile light as well, because what you're talking about is how these developing and certainly middle income countries can take advantage of the fact that they don't have, and I really liked how you said those vanity diseases, and can really utilize technology such as the open source or even the proprietary data mining software that can really bring in these various streams of data sources and can really help what you're describing. You're saying aberration detection, but that's nothing more than signal detection. Yep. And to look at it and to see how that signal detection and perhaps some predictions can be used for public health action. And that's exactly what public health surveillance is all about. So thank you for your insights. Thank you. I think I have to turn this back to Jagdish at this point for one or two people, and then I'll come back. So thanks again.
Thank you, Greg. And thank you, Sally, for really a very, very good presentation. And you raised some valid points. Couple years back, we were in Barcelona and we were looking at some toys which were AI driven. And me and Anil were talking about it and with that vendor. And we asked him a very clear question that, okay, as long as this, child plays with this toy, that's all right. But if the toy plays with the child, what happens? So, we need to have the evaluation criteria and the checks and balances about it, the AI, because all these cutting edge technologies, and you raised a very good point about the private good and the public good. Yes, that's right. AI is so impactful. It needs to be having a people first approach, and it needs to be developed that way. Thank you so much for bringing up that point. And that's exactly what Naresh, our next panelist, I will request him to ponder, because his organization, Navya, is doing great work. And I would have that question for Naresh, that what are the checks and balances we could really place for AI and digital technologies. When we are going all out, working with the patients and the public at large, and also if there are any evaluation criteria in place. This is of a special interest to me and Anil both, because we are currently in process of constituting an ethical review board for AI driven technologies for digital health. And so we'll really love to hear from you, Naresh. Naresh, please, on to you.
Thanks, Jagdish, for the question. And it's actually great to go after Sujay and Sally, because they bring up a lot of the actual benefits of using AI for task shifting and getting lower skilled people to be able to do what you need at a higher skill level, or to be able to use signal detection for public surveillance, like the example on the prediction of the Zika outbreak. So you see the great benefit that's available there from the use of data mining and AI. But one of the things to consider, so my background is both as a clinician in clinical informatics and machine learning, but also as an emergency physician who day-to-day sees patients and looks at clinical trials. And so having both of these thoughts in mind, what comes up immediately is, I think the culture of using AI in healthcare would benefit a lot from thinking of these as clinical interventions. You know, the minute you have your mindset, especially in the health services area, maybe not in the public health domain that Sally was talking about, but especially in health services, when we're talking about machine vision or when we're talking about clinical decision support, it really truly is a clinical intervention in the health services area. And once you put that lens on it, it shifts your focus from measures like what's your precision, what's your recall, what's the AUC of your ability to predict something, to actually what's the change in the clinical outcome that you're interested in, right? Like what's the actual behavior on the ground that you're actually changing. And I think too many of our data sets and studies in AI or case reports are focused on, you know, the technology itself and AUC and how great it is at predicting what a human can do, rather than shifting and looking at on the ground, what behavior did you actually change? And if you take an implementation science view on it or a healthcare services view on it, you can actually start looking at that. So I just want to give a quick example of how we try to do that, because obviously with medicine, anything that you do is, you know, it becomes pretty critical that you get the validation from the clinicians on the ground, right? So Navya, we just presented this data at ASCO, at the American Society of Clinical Oncology Conference in 2020. It was all virtual this year, but in 2017, we had an oral presentation there too. Mainly, we've been able to get the trust of the clinicians, of the oncologists on the ground, because a lot of what we do is basically clinical follow-up on actual changes in outcomes. So our process at Navya is that we have a very human process in the beginning for data collection, and then we run it through our clinical decision support engines, looking at various other patients to be able to predict, you know, what's the best treatment pathway that should be given for a particular patient in cancer, to be very short about it, right? But the way we studied it is we looked at about 2,000 patients across the country in a very heterogeneous data set in India, and we actually looked at what's the on-the-ground change in their treatment plan itself. So for example, what we measured was before using the AI-based intervention, what was compliance with guidelines, and afterwards, how did we actually change guideline compliance on the ground, right? So a very simple example of how, if you change your mindset from, you know, can I just predict what the human expert says, to push it one level down the value chain and say, can I actually measure clinical outcomes on what did the patient receive? And then 2 years later, can I actually look at clinical outcomes? Then now you're actually strengthening your case for the safety and usefulness of an AI-based intervention. We've also looked at other patient-centered outcomes. For example, we've published data at European Society of Medical Oncology, looking at how much cost savings did the patient actually have by using an AI-based intervention versus an in-person intervention. How much time savings did they have? So there's many different ways in which you can actually start, if you think of these as clinical interventions, especially for stuff that's super critical, like, you're talking about, epileptologists and task shifting to primary care, for example, or we're talking about oncology and treatment pathways, or we've talked about machine vision and detecting cancer in x-rays and screening. These are important things. If you make mistakes, you're going to have trouble, right? And so I think the focus has to shift a lot more from where we are in publishing the data on, AUCs and sensitivities, specificities, precision, recall, all of that, down to the actual clinical outcome, change in behavior. What's the patient-centered outcome that you're looking at? And yes, it involves more time and effort, but it's critical. And that's how you know that you're developing good technology, is if you're actually be able to test it out on the ground and, get a real answer that changes outcomes. So that's the way that, I think we're thinking about it. And I would invite more questions on that as well.
Thanks, Naresh. We have we have viewership on YouTube and Facebook Live. That's the new norm. People register less and view more on the YouTube and the Facebooks, and so we are not getting the questions from there. But I'm sure in like last webinars, we'll be getting them later on and passing them on to you. So there's a large viewership right now, but they all are on Facebook and live on Facebook Live and the YouTube Live. So I'll pass it on back to Greg for requesting Bhavna. Greg, over to you, please.
And with the interest of time, I think it'll be good to ask Bhavna one good general question. And Greg, you decide.
Greg, you have to unmute yourself.
Thank you. Bhavna, it is good to, it's good to connect with you. Hello, I know we're under time limits here, but we've heard so much. We've heard so much. How do you, so we're all of the webinars so far have been talking about the digitization of technologies for health. So how do you see this digitization technology for public health nutrition, right? Which is an area of JSPH's, how do you see it?
As far as, thank you, Greg. Thank you so much for introducing me. These trio series of webinars on digitally transforming global public health has given a plethora of amazing experts with abundant experience in a great and unique combo that is medical and IT together as a panelist. For this, I would like to extend my heartiest appreciation to Dr. Anil Purohit for bringing such a knowledgeable expert from across the globe to this platform. Thank you so much, Dr. Anil Purohit. I'm also thankful to all panelists for sparing their precious time for this cause. And now I request to all requested panelists, please continue this journey by penetrating your knowledge and experience to the community by training our students. Our students are from India, Bangladesh, Nigeria, Mozambique, and of course from Afghanistan, who are actually representing the communities of much needs. They would take this journey further to the ground level. So this way, really, we can transform the future of public health digitally. These webinars have supported the fact that digital technologies that has revolutionized the area of medicine and public health. This COVID area phase is also given as a turn as a teacher and has strengthened our realization of importance of this digitech. We attain our goal with minimum risk. That's what we have learned from all these webinars. As far as your second part of the question, really we are pleased to inform you that we are actually have started basically health IT or health informatics using IoT, AI, blockchain in our specialization program and both our graduation and post-graduation, where from this academic year and that is powered by Microsoft and supported by our partner Mobilite in DigChain. at the end, I would say that we think technology cannot replace our public health experts, but experts who use IT or digital technologies may replace those who don't. So for this reason, we are upgrading our training modules to make more our scholars and students more competent as far as employability and enhanced skill sets are concerned. We need to improve the conventional teaching in the field of public health, and specifically public health nutrition we talk about. The last time we have learned this message from our one of the first webinar from Praveen Abed, that whatever the data collection is there as far as nutrition is concerned, we have to be specific. There should not be garbage collection should not be there. So that's what we can say. And as far as Jodhpur team, this is basically academia team of Jodhpur School of Public Health. We have initiated more and more training as far as AI is concerned, blockchain is concerned, whatever is health in informatics is there. Thank you.
Thank you, Bhavna. You know, what you say has actually been what I've been doing myself. Seems like COVID-19 has allowed me to do even more learning. And so what I have been doing is to upskill. I've been upskilling in data science technologies and just how to think about it. You know, I've been using certainly Python and trying to do some programming there, and trying to learn how to use some data mining software like SPSS Modeler or KIME, and just looking at how to bring all of these technologies to bear and what I have to do, you know. And I think that's what our students are almost demanding from us, is that we keep up with this technology to help them solve what they see as the problems of the next decade, if not beyond. So very exciting. Thank you. Thank you. Let me look at the agenda and see, who do I turn this back to?
I'll take it.
Okay, thank you.
Thank you, Greg. It was a wonderful panel. Thank you all very much. I think we all learned a lot. I'm really thankful to Sally and Hormuz, who had to wake up around 5 in the morning, 5:30 in the morning, West Coast time in the United States. And we have learned a lot today, and this is just the beginning. I want to take this panel forward. We will communicate. We will come out with a report. And right now, going forward, Kandarp and Rhea is going to give us a small report summary as their reporters, and they'll be really brief because of the time we are running out. And over to you, Kandarp.
So, good evening, everyone, and good morning to all in US. We thank you for being the part of the panel, and it was, a very enriching experience to hear all those words of wisdom from you all. And I would like to start off with Dr. Suresh, who talked about imaging, how imaging, AI, graphic design, and ultimately augmented reality can help with the interventions. Thank you, sir. And then we had Keshav, who is a brilliant speaker, great presentation, by the way, sir. And we had a lot to learn about the Quit with Bella and our study, which we are working on. And the best part of it was the personal nature of the interaction with the people who are using it. Then moving on to, thank you for that. And moving on to commerce. Great presentation, by the way, and usage. I mean, a lot to learn about the usage of machine learning models, which you certainly use in your study. And it also told us why statistics is important to calculate and compare any variable which we are looking for. And also, it also told us about the data cleaning and feature engineering, which which should be basically the things we should emphasize on. So thank you for that. Moving on to Dr. Akshay. You raised a very good point that we are lacking good radiologists, and for basic imaging jobs and for augmenting the services, we should also replace the radiologists with the AI, which can be done. It has potential. And you also told us a very important topic about hype and hope, which again is a very important thing. And thank you for that, sir. Moving on to Mayank. Great work at Medicals, sir. Nice work you're doing over there. And talking in a layman's language, how actually people are using technology, specifically social media, WhatsApp, smartphones, and wearables as far as health is concerned. was actually great to listen from you. And it's good to have interns at the JSPH. Also, Yamini was also very good about things. And now, since we are talking of interns, I'd like to move on to my co-rapporteur, Ria. So, Ria, can you please take over from there? Thank you.
Yeah, just like Dr. Kandar mentioned, it was wonderful being on this panel and kind of getting to hear about all the wonderful work that each one of you is doing. So thank you so much to everyone. So I'm going to continue off with Mr. Adarsh, and thank you so much for a wonderful presentation on the innovative machine learning and techniques and technologies that you're developing. You're doing great work, especially in the COVID scenario. Next, we heard from Ms. Vibha. Thank you so much for going through and explaining the broad nature of health technology assessment and how it impacts the digitalization of healthcare. Next, we heard from Mr. Sujay. We learned about the connection between AI and other new technologies and point of care diagnostics, and in addition to kind of the importance of reducing the load on a lot of clinical specialists. Next, we heard from Sally Stansfield, and she had a wonderful presentation on the importance of surveillance and population health services. It was really amazing learning about how AI can be used in public health surveillance to benefit developing countries, especially. Next, we heard from Mr. Naresh, and he kind of talked about the need to create a culture of the usage of AI in healthcare, and how this will definitely help create better interventions, especially clinical interventions. And you provided a great example of how AI intervention works in Navya currently. And then lastly, we heard from Ms. Pavna. Thank you so much for all your great words on the courses on technology and health technology in public health, and how they're a boon for public health scholars that are coming up. So yeah, thank you so much to everyone for sharing all these wonderful words and information.
Thank you so much, Kandarp and Rhea. And as I said, we will be coming back to you on the WhatsApp group, having you review the reports we produce, and then we plan to publish at least 2 reports out of this. And over to our Honorable Vice Chancellor for the closing remarks. Dr. Padi.
Suresh sir? Suresh sir, can you hear me?
Yes. I think you have, yeah, I can hear.
Yeah, can you turn on the video and we just
so if you could give us the closing remarks.
Yes, sir.
Thank you.
Yeah. Thank you very much. Thank you, especially thanks to Dr. Anil Purohit. Every time I listen, it is a eye-opening session, as well as very soothing to learn that so many works are happening in the health area or the health service. So much the intellectuals and so much the digitization and digital technology is involved. It is really great to know. And I believe Anil Purohit sir is a living encyclopedia, knowing all the people of the whole world, and getting together and having asked everybody to talk for the benefit of everybody. I'm grateful and thankful to all the panelists of sharing such a wonderful, knowledgeable sessions, and I thank everybody. And thank you very much.
Thank you. Over to Rahul he does the little handshake, right?
Yeah, so it's a signature, this thing. So I want everyone to just turn on the video and say goodbye to everyone. Yes, so Akshay, if you can turn on the video and say bye-bye. Thank you so much. We'll all meet soon in the next webinar. And I again thank all of you from the bottom of my heart for supporting Poornima University, Jodhpur School of Public Health and Indic Chain. And I'm sure that with contribution of everyone, we'll come out with flying colors. Thank you. Until next time. Bye-bye.